Huh.
Uh, Mrs. 50-year-old premenopausal Paris lady, uh, graduated from Bangalore, resident of Bangalore, upper middle class, homemaker by occupation. She is complaining of a central patient. She was apparently all right 3 months back. Then she complained pain in the lower abdomen in past 3 months. History of discomfort in the lower abdomen she describes as a feeling of heaviness, more association with the increased intensity of pain. History of recent onset of difficulty in passing urine for past 15 to 20 days. So 50-year premenopausal lady who was apparently all right 3 months back to start with the present pain in she had sudden onset of severe spasmodic pain in the lower abdomen, relieved partly with the analgesic and antispasmodic taken for a week. No history of femur vomiting during this episode. Later on, pain persisted as the moderate intensity, dull aching pain, and vague discomfort confined to lower abdomen since 3 months. With no radiation, no aggravating factors, and partly relieved by analgesic. There is no relation of pain with the movement and the bowel bladder habits and postural variation till last 2 weeks. She gives the history of difficulty in passing urine for past 15 to 20 days, which she says that she has to strain to pass urine with increased time to void. No history of increased frequency, urgency, feeling of incomplete voiding, burning sensation, pain while passing urine, and change in color and consistency of urine. No history suggestive of hematuria. She says intense where she had increased intensity of pain in abdomen. It was more disturbing after she has developed these mixturational disturbances, which of late had forced her to take medical attention. She denies any history of distension in the abdomen or noticing any mass in abdomen or any other swelling and lump anywhere else. History of chronic low back pain for the past 7 to 8 years, which was relieved with rest and no obvious relation with the prior menstruation present condition. No history suggestive of any neurological deficit or the sensation in the lower limb. No history suggestive of any masculinization changes, voice, acne, excessive unwanted hair growth. No history of altered bowel habits and melena. No history suggestive of any chronic pain in liver and the lower limb swelling. No history suggestive of dyspeptic, easy fatigability, shortness of breath, chest, hemoptysis, and jaundice. No history suggestive of weight loss. However, she says she has aversion in the intake of diet for the past 1 month, which she ascribes to fear after onset of present problem, and no history suggestive of loss of appetite. Prior to 8 months, her menstrual cycles were regular. LMP 6 months from the date of examination. She had normal flow of 3 to 4 days with no history suggestive of increased bleeding, pain during periods, no passage of clots, and no history any abnormal discharge and PV. No history suggestive of any intermenstrual bleed, no history suggestive of any postcoital bleed or dyspareunia. So no history of any past history आ गया मैम.
Mm-hmm.
No,
Finish history will discuss.
no history of any
Hmm.
similar complaints in the past. She had no comorbid illness and chronic illness in the past. She had history of tubal ligation after first childbirth 20 years back. No other surgeries in the past. No history of treatment for infertility, OCP, IUCD, HRT. No history of exposure of any chemical radiation. She consumed vegetarian diet, no history suggestive of addiction and habituations. She has no sleep disturbance, no history of any drug allergies, no significant loss of weight or loss of appetite. She attained menarche at the age of 14, married at the age of 25 years, first childbirth 1 year post menarche. She is mother for single child 24-year-old, delivered by full term normal vaginal delivery. Has breastfed for the 1.5 year. Para 1, live 1, normal flow in prior menstruation cycle, about 3 to 4 days in the 25 to 28 days cycle. No significant family history, upper GI and genitourinary in family members. She has 2 siblings, an elder and younger brother who are in good in health. Her mother is also good in health. She has consulted gynecologist prior to visit our center, which was referred by the gynac for further management. She had USG abdomen and pelvis both done before. To summarize, 50-year-old perimenopausal lady with 6 months of amenorrhea, homemaker, presented with the chief complaint of persistent dull aching pain in the lower abdomen of 3 months duration, associated with heaviness, vague discomfort, and recent onset straining to pass urine, and no other symptoms of dysuria, no bowel disturbance, no swelling in the lower limb, or any obvious associated symptoms, or no history contributing of any distant metastasis or family history.
Okay. So, first slide, Saumyta.
Yes, ma'am.
So, what is importance of age here?
Any early patient presenting with any lower abdominal mass, premenopausal or postmenopausal, there is some significance. Postmenopausal women is coming with the mass likely to be malignant. If early female patient less than 8 year is showing this complaint, prepubertal, then it's also more chances of malignancy. But in
Okay. From your history,
reproductive age group, if some patient saying this complaint, then it can be some benign etiology, or it can be both.
so from your history point of view, what will be your differential diagnosis in order? So, take it premenopausal. Okay, some people will not accept the word perimenopausal. So, premenopausal. Okay, and Paris lady. Okay, not nulliparous. Paris lady who presented with pain abdomen of acute onset, which was later relieved, but she has some vague complaint, dyspeptic symptoms and all, with no bleeding PV and no distant metastasis features. So some urinary symptoms. Okay. So so what do you think with this two positive things, that pain abdomen with vague symptoms of some abdominal discomfort and bloating and urinary symptoms? What comes to your mind? What are differential diagnoses that come to your mind?
UTI, ma'am.
We would think of pelvic pathology first. So first of all, whenever you tell differential diagnosis, you say it from the anatomical point of view, etiological and pathological point of view. Okay.
So we would first, considering the history and the symptoms, we would think of some pelvic pathology, and considering a premenopausal Paris lady, pelvic pathology could be either genital or gynecological, urological, or a GI pathology is what we could think of.
Can it be a retroperitoneal mass, Jessica?
With dyspareunia and everything, more sounds of a pelvic pathology rather than a retroperitoneal mass.
Why not?
And it can be, ma'am, like early satiety pain. It can present like this.
There's no history of dyspareunia, by the way. There is history of dysuria. Okay?
Yes.
So tell me.
It can be retroperitoneal also.
So suppose anyone in the group can answer. Okay? If you are asked because history is vague. Okay? So you give me 5 differential diagnoses in order. So what will be your differential diagnosis? So classify it, like whether it is, I would like to give benign or malignant, and anatomical, etiological and pathological. So what will be your first diagnosis? It's okay, no problem. Like at this point, you need not tell it is ovarian mass or anything like that. Okay, even if you tell, it's not wrong. Okay.
PID or endometriosis. Like it is
50 years?
50 year old, so ma'am, we will go for like maybe it is a ovarian mass because there are no GI symptoms as such, and
Any adnexal mass, ma'am, arising from ovary or fallopian tube.
So first diagnosis, what do you think? It's a benign mass or a malignant mass?
Ma'am, some
At this
bladder,
point, we
urinary,
cannot rule out whether. At this point, it would be difficult to say whether it's benign or malignant. So we would
Okay.
keep the options
So
open.
first diagnosis will be an adnexal mass. Okay. Can it be a uterine mass?
Yes, ma'am.
can be
So something related to
bleeding.
pelvic mass. Okay. Genital urinary system may be benign or malignant. Okay. Genital system. Okay. Take it uterus or ovary. Second,
Broad
any
ligament.
peritoneal, any pelvic mass, ma'am, any pelvic mass.
Any metastasis, any
no,
metastasis.
is a pelvic mass. Okay, fine, but you should be more specific.
It could be either a
Metastasis in the pelvis or appendicular mass.
Okay. If you think metastasis in pelvis, who is that? Dishita. Avneet.
Yes.
Okay. So, if you think metastasis in pelvis, what is it going against in this case, ma?
No GI symptoms, ma'am.
No. Suppose what is the most common that metastasis to pelvis? What you are thinking in your mind? Krukenberg,
Yes.
if I'm not wrong.
Yes.
Okay. So Krukenberg will most commonly present with GI. Okay. In a what mostly let's say not 50 years whose menses has stopped for 8 months, though she's not menopausal, but she's not menstruating. So Krukenberg is more common in premenopausal ladies. Okay, young reproductive age group. Then that goes against it. Okay. So if you're thinking in terms of Krukenberg, okay, it can still be metastasis from elsewhere. Okay.
Okay.
Right, because we don't know it is a bilateral mass or something. Okay, it's a mass, that's it.
Yes.
If you are thinking in terms of a mass, still we don't know it is a mass also. Okay, so keep your mind open. It's not a mass. So what else can be? She has some dysuric symptoms.
It could be
Bladder
urethral
mass.
cyst,
Yes, like it can be mesenteric cyst,
mesenteric cyst,
intestine mass.
urethral cyst.
Mesenteric
Appendicular
cyst will have this kind of symptoms.
Not usually, ma'am. Like if it is large, it
Unlikely,
can
no?
cause pain.
So
And
that's
it
why
can,
I'm asking in order. First, you told abdominopelvic mass, most probably of adnexal origin. Accepted. Second, you told it can be metastasis. That too, you told adnexal mass. Then bladder mass. Can it be a bladder mass? It can be, no?
it can be.
So she has, though not hematuria, but she has dysuria. So most of the bladder masses, they present with painless microscopic hematuria. We discussed last time. So
Yes.
it can be still a bladder mass. So keep your mind open. Still, what mass it can be?
Appendicular or
ma'am,
appendicular mass.
Any rectal gist also.
Pelvic cyst.
Pelvic ectopic kidney mass.
Gist.
Oh, very rare. Yeah, don't see how many pelvic ectopic kidneys you have seen. Who is that? Rakesh.
Tuberculosis, ma'am. Tuberculosis. Tuberculosis, ma'am.
Yeah, it can be TB abdomen, na? See, why you people are thinking you're stuck to mass? Did I tell it is mass in history? No. So, yeah, tell based on her symptoms. What else? Which can present with acute pain abdomen.
Appendicitis.
Ectopic
It can be an
pregnancy.
appendicular mass.
Appendicular mass, yes.
It can be appendicular mass, yes. Yeah, now you're coming to this one. Yeah, tell. Still? I've asked you 5.
Then
Ectopic pregnancy.
retroperitoneal mass.
Retroperitoneal. Ectopic pregnancy is difficult, Saumyta, but 50 years.
Ma'am.
Sorry, whoever it is. No. You're not wrong, but 50 years perimenopausal lady is
With
difficult.
symptoms of amenorrhea.
So anyways, amenorrhea, fine, but it can be due to menopause, no? So
Yes.
anyway, you're not wrong. completely, but keep it at last. Okay. So we got 5 differential diagnoses. Okay. It can be of tubo-ovarian adnexal origin. Okay. It can be tuberculosis in inflammatory pathology. Okay. So then we got
TB.
either bladder mass, retroperitoneal, appendicular mass. Okay. Gist also is possible. Retroperitoneal, you can tell it is somewhere in the pelvic gist also is possible. Okay. Right. So this is your differential diagnosis. Now we will like sort out based on this one. So tell me, no. First, chief complaints, ma'am. No. Huh. So what has this parity and like abdominopelvic masses? What is the relation?
In cases of ovarian masses, more parity is protective.
Multiple pregnancy is a protective factor in this.
Okay.
Nulliparity.
In other words, nulliparity is a risk factor. Okay, right. Then, can it be cervical origin? Something of cervical origin. She has dysuria also.
It usually presents as a bleeding per vaginum.
It is okay, bleeding per vaginum, but it is not there. Okay, right. So, why I asked cervical? Something in relation to that. So, multiparous, it is more common. Anything has something with infertility that is related to tubo-ovarian masses? How is infertility?
Infertility increases the risk of.
Does the treatment of infertility increase the risk, or infertility per se increases the risk?
Infertility increases the risk, ma'am.
How much is the risk?
Treatment of infertility increases the risk.
Yeah. So treatment of infertility increases risk for what?
Because we are giving SCG, na ma'am, what we are giving from outside.
Huh? No, what you will get for infertility?
Follicular growth कराने के लिए we are giving some injections, na.
What injections?
Clomiphene citrate.
So what will they cause? What will they cause?
Ovarian hyperstimulation.
Ovarian hyperstimulation syndrome. Okay.
Unopposed estrogen will be there.
Yeah. So what is the etiopathogenesis behind ovarian cancer? How does it form?
Prolonged estrogen.
Two hypotheses: ovarian incest theory and
incessant ovulation theory. Yeah. What is this incessant ovulation? What is incessant ovulation theory?
Continuous ovulation.
Continuous ovulation. A break in the ovarian surface epithelium, and then there is regeneration. So during that time, there might be any dysplasia or
repeated break and repair of
yeah. So what happens is this in ovarian hyperstimulation? That exactly is what happens. That's why they'll be at risk. Okay. So you are stimulating an ovary to produce follicles. Okay. To produce ova. Okay. So repeated trauma, in other words, to tell it in simple words, repeated surface trauma and deposition of some dysplastic cells, which subsequently develop into malignancy. Okay. So right. Fertility treatment, does it cause high grade cancer or low grade cancer?
Low grade.
Yeah, it causes low grade cancer. So tell me, I've told premenopausal. So how is menopause related? I mean, the menarche and menopause related to ovarian pathology?
Most common age group in which ovarian cancer is seen is between 60 to 65 years postmenopausal females.
Early menarche.
Let us not take it as ovarian cancer, but
yeah.
What will be the risk factor?
Early menarche, late menopause, because estrogen more the exposure, more the risk. Unopposed.
Okay, what is early menarche?
Less than 9 years.
9 years.
9 to 12 is normal. Less than anything before 9 years is early menarche.
What is late menopause?
For Indian scenario and Western population. For Western population, anything more than 53 years, and for Indian, it is more than 50 years.
48 plus or minus 5 Indian scenario. and whereas in Western it is 50 plus or minus 5. Okay. So anything to do with the infertility, hormone replacement therapy, something, any relation? If so, what is the relation?
OCP is
Any
protective.
OCP is protective. Which OCP is protective?
Combined.
Yeah, if I ask you to arrange in order, combined estrogen, progesterone. So which is protective?
Combined is protective. Progesterone has no doesn't
No
make
such risk.
any
Estrogen
Yeah.
is high risk.
Good. So she is a Paris lady. So anything relation to pregnancy and abdominopelvic masses?
Nulliparous is associated with increased risk for ovary as well as endometrium.
Anything related to delayed pregnancies?
Pregnancy itself can be a DD, ma'am, like in reproductive age group.
That's fine. Any relation to late pregnancy and abdominopelvic masses?
Age of chest, first childbirth more than 35 years is also
Yeah,
one of the
same thing as in breast. Okay,
Breast.
more than same thing. So somebody told pelvic inflammatory disease, right? If I'm not wrong, I think it was some boys, someone. So PID is in young people. So tell me anything that is related to PID and causes increased risk for abdominopelvic masses.
Endometrioid type of CA ovary is associated with endometriosis.
Yeah, endometriosis. Okay. So again, in this endometriosis, sometimes they will ask you grades. Okay. Just read the grade difference. Okay. There are 4 grades, so you read the grades first.
Endometriosis,
Okay.
PCOS, and PID. These are the three benign etiologies which are implicated in the pathogenesis of early epithelial ovarian cancer.
Yeah. Okay. So why PCOS?
PCOS.
Infertility, then we will try for fertility. Same pathway.
What happens in polycystic ovarian disease? What is the pathology?
Hyperestrogenism, na ma'am.
and ovulatory cycles are more
Anovulatory cycles.
Hyperhirsutism, and one more.
and keratosis nigrans.
So anovulatory cycles mainly. Okay, these contribute to this one. Okay, breastfeeding and ovary cancer.
Breastfeeding more than 12 months is protective for ovary.
Masses.
Weak protective effect.
They're protective or yeah. Okay. Same. Whatever is for breast, that is for ovary also. Okay. And how is I've asked for history of any past surgeries. So what surgeries we are interested in? Don't go to that page. Just tell.
Hysterectomy.
Yeah. So how much protection? Like relative risk and all. If you know. Okay. What is the relative risk of smoking with ovarian neoplasms?
2.5 relative risk.
Yeah.
2.65.
Yeah. So So tubal ligation is protective. Okay. So fine. So now pain in the lower abdomen for the past 3 months. Okay.
Hysterectomy and tubal ligation risk 30 to 40% reduction in the risk of ovarian cancer.
Yes.
According to Davita. ऐसा क्यों है? Because presumably due to interruption of some blood flow to the both ovaries.
No. Whenever we do, there is different. What is difference between tubal ligation and tubectomy?
Tubal ligation, we are putting some clips just to interrupt the transfer of ovum for fertility. That and tubal.
What happens in tubectomy?
So the PID, if there is PID, so then that transmission will be less. The tubal ligation is done.
So what happened? Actually, to ask you about this, where is the origin of ovarian malignancies presumed to be from?
Fallopian tube.
Yeah, what are they called?
Stick lesion.
What is stick?
Stick.
Serous
tubular
intraepithelial.
So, what happens in this tubal ligation and tubectomy? So, when you are interrupting the transmission of whatever the cells are there, okay, the abnormal cells from the surface to reach that area of dissemination. Okay, so that is one protective factor. So then, lower abdomen for past 3 months. Okay, but she had acute onset of pain abdomen. So what are your differential diagnosis for this?
Torsion.
TB.
Torsion.
As it is premenopausal, perimenopausal, fibroid can be like less preferred like DD here.
That is see, fibroid. What kind of fibroid will present with acute presentation? Malignant red degeneration. Okay.
Yes.
So that is not common in this age, right? Okay.
Yes.
So one is torsion ovary, accepted. Next. Don't confine yourself to ovary. Something adjacent also you should think.
Appendicitis.
TB.
Yeah, appendicitis. TB with what do you think?
Chronic
Bowel.
pain can be there. Huh?
Chronic pain, but acute pain?
Some
She had acute pain,
Sometimes
no?
perforation
It's
में
still
acute pain
obstruction.
होता है.
Yeah, it can lead to obstruction perforation. Okay, fine, accepted. Okay, so any history of fever I have asked. So that's to rule out the same. Okay.
Evening rise.
So any inflammatory pathology or even in torsion, it can occur. So fever, vomitings. Okay. So that is pain is there up. Okay. So next before slide ma pain. Yeah. So whether it is relieved with analgesics or antispasmodic, and whether any relation to postural variation. Why relation to postural variation? What is our another system of differential diagnosis that we have considered here?
Postural variation.
What happens in a something colicky pain?
Renal
Patient will not like.
Yeah. So calculi, due to calculi. So with posture, they will not. They'll be jolting on bed. So that is we have to rule out all the differential diagnosis what we have considered. So one by one. Okay. So then next after pain. Next page. So why difficulty in passing urine, you think, in this case?
large mass causing compressive symptoms.
Yeah, that is one possibility. Or it might be due to something in relation to bladder itself.
Bladder mass.
Okay.
Yes.
Yeah. But here, typically, she gives history to pass. She's taking increased time to void. Okay, so that is something relation to straining to pass urine because of compression. Okay, more of compressive pathology she's pointing towards. Okay, so there is no history of increased frequency or anything or any hematuria. So that rules out any bladder pathology. So we ruled out bladder. Okay, one. Next, so distension of abdomen.
Distension can be due to the adnexal mass, big mass. Second, it can be due to some GI mass causing obstruction, or per se, like even a large GI mass can produce distension. Third, ascites can be there.
Constipation, obstipation.
Yeah, so none of the constipation or obstipation is there. So bowel disturbances are not there. So GI can be ruled out, right? So then next, distension can be either due to ascites or due to a mass, right? Next.
Chronic back pain.
Yeah, why chronic back pain?
Big mass.
Pelvic pathology.
Yeah.
So retroperitoneal mass can cause. Then any other differential diagnosis in which we have considered can cause chronic back pain? Out of 4, out of 3, we have ruled out GI. We have ruled out this one.
Ovary can cause, ma'am.
Urinary bladder. Ovary itself can cause.
Yeah.
So ovary can cause. Any uterine?
Uterine
mass
less
can also cause.
Lower limb. Lower limb edema.
Lower lymph nodes.
Yeah, lymphadenopathy can cause. Okay. So any DVTs can cause. Okay. So these are the things. Next. So why features of masculinization?
If any hormonal variation.
Some like.
Can you tell me few things? What was there in my mind when I asked for features of masculinization, and why in this group?
Stromal tumors.
Yeah, stromal
Sex
tumors
cause
like Sertoli cell, bleeding Sertoli.
But ma'am, wouldn't that be in a reproductive age group 40?
Yeah. So this granulosa cell tumors is common in what age group?
50 to 65. It has a bimodal and adult.
Yeah, it has adult and juvenile. Okay. So nearing. She's in between, so I've asked. Okay. So then dyspeptic symptoms. Why? To rule out any upper GI pathology. So you told metastasis, right? So there is no metastasis. So your 5 diagnoses with 3 are ruled out. Okay. Next, loss of weight and all are constitutional symptoms. Okay. Then she particularly says that I have aversion to intake of diet, but there is no significant loss of appetite. I'm not having any like I want to eat, but on seeing the food, I'm not having feeling to take the food. So that is the typical symptom of any chronic
compressive symptom.
Yeah, malignancies. It is the typical symptom they present with. Okay. So next. So what is cachexia? What is anorexia?
Anorexia is loss of appetite, like not feeling obesity.
Cachexia is loss of weight, loss of appetite with other constitutional
asthenia and all. Okay. Asthenia, anorexia, and anemia. Okay. So these 3 are the triad. So what is the amount of weight loss when you describe it as significant cachexia?
More than 25%.
Correct. 25 to 30% around. Okay. So yeah. So her prior menstrual cycles were all regular. Okay. So there was no clots or anything, no abnormal discharge PV. Okay. No intermenstrual bleed also. So these all rules out your what pathology? So if we take in gynec, now either it can be gynec or it can be retroperitoneal, right? So we are left out with only 2 options.
The moral of the story, ma'am, ovarian mass is the diagnosis of exclusion.
Yeah, so you have to. So when you give a DD, you should in abdominal masses, abdominopelvic masses, never give a single DD. Okay, always remember. If you give a single DD, they'll think that you know the case. Okay, don't give a single DD. So give always when you're going to present case. You have to have in mind 3 most you can't tell whatever you want. So like he told ectopic kidney. That all things are very rare. Okay, it can be. See, in medical, this one nothing is impossible. But tell most 3 probable diagnoses and tell it in order. Okay, so that it gives a good impression. Okay, so yeah, then so these are ruling out any cervical or uterine pathologies. Okay, right? Next. So in past history, tubal ligation we discussed. So what is relation of IUCD?
IUCD is not a risk factor, I think.
What happens with IUCD insertion?
They secrete levonorgestrel in the persistent amount, so that what is levonorgestrel क्या करता है याद नहीं आ रहा.
What is Mirena?
Mirena is the IUCD name, na ma'am. It releases a constant amount of levonorgestrel.
So you tell me, is pregnancy protective or risk factor?
Pregnancy is a protective. Also, it will increase risk then. Pregnancy is protective.
Pregnancy is protective.
Yeah. So what does
Mirena
IUCD
and
do?
IUCDs will be protective then.
Because OCPs are protective, but they are generally having maybe single agent only.
So, like somebody told, no, progesterone has no effect. Okay.
Yeah.
So it is like something like OC pills only. Okay. So it may not have that much protective effect, but certainly some studies say that IUCD to some extent is protective. Okay. So yeah. So any chemicals, radiation exposure, you know that relation to adnexal masses?
Talc exposure.
Talc exposure.
Talc exposure. Correct. Okay. So where do you use talc?
Malignant that pleural effusion.
Due to rashes in the.
Sorry?
Chemical
Yeah.
is there.
That no.
Rashes in the
She's talking
private
about
part.
different talc. There was some theory saying that usage of talc in the perineal region will also will also lead to ovarian cancer. She's talking about that talc. Okay. So this talc is different. Okay.
This talc
Then?
is different.
No. This what he told is pleural effusion talc. Okay.
Okay.
What you are telling is relation to ovarian neoplasms. Okay, that was one.
Only increase.
That was one theory. Yeah, that was one theory which was thought of, but it doesn't have any substantial evidence.
Ma'am, in
Okay.
a recent new data, na, they have mentioned this line. Talcum silicate, although the animal model may do not support, but there is meta-analysis who supports the increase is approximately 35% with genital exposure to talc.
Okay, it was not there in
हाँ,
when
ये
we
अभी
read
मैं
that.
recent में ज़्यादा पढ़ के नहीं बैठी हूँ ना, इसलिए I have opened data.
So then you consider that. Okay, talc that application of talcum powder in the genital perineal region also increases the risk.
WHI study we have to quote for this.
Yeah, Women Health Initiative study.
So,
and even for OC pills, PCOS, all this have studies.
So genital talc exposure, premenopausal women and postmenopausal women using HRT, and women with variants of glutathione S transferase M1 and glutathione S transferase T1. These all are the risk factor for the ovarian cancer according to this WHI initiative study.
And how many years of usage of OC pills? What is the duration?
1 year 10%, 5 year 50%.
No, minimum usage that it can be protective.
1 year.
5 years. Okay. Right.
1 year use protects 10%, 5 years 50%. So I told you that.
5 years. 5 years. So minimum usage is 5 years. Okay. Next. Personal history. So we discussed about smoking relative risk. Next page. So any other We discussed about loss of it. Yeah, this full term vaginal delivery, all this we have discussed already. So next page. Yeah, tell me some syndromic association with ovarian neoplasms.
Hereditary breast ovarian cancer.
Yes, how much? BRCA1, BRCA2 कितना है?
1 is
Per ovary.
60%, 2 is 30%.
Tell always change.
In ovary, like hereditary can be, I think, 10 to 15% due to BRCA.
BRCA
you're
1
telling
is around
combined.
50
If
to
you
1 is 50 to 60%. BRCA 2 is 20 to 30%.
That is risk of ovary in BRCA, na? Like in
Ovary in BRCA.
In ovary, what is the percentage of that hereditary or BRCA associated? That I'm telling. Maybe 10 to 50%.
Yeah. The lifetime risk for BRCA1 will be around 60% and BRCA2 will be around 30%. Okay. So, any risk of, and what are the other syndromes which you know?
Lynch
syndrome.
Yeah, Lynch syndrome, what are the genes?
MLH1, MSH2, PM6, PMS2, CAM.
Yeah. So it increases what all cancer?
GI, then endometrium, ovary, renal, breast,
GI बहुत बड़ा है ना, कौन सा कैंसर है HNPCT में?
colorectal,
colorectal, duodenal, upper colorectal, duodenal, stomach, urothelial cancers.
What is the most common other than colorectal cancer?
Endometrial.
Endometrial and ovarian. So how much is the lifetime risk for HNPCC?
40.
It's around 10%. Okay. Yeah. So then any other syndromes? Can Peutz-Jeghers cause?
Cowden syndrome.
Yeah, P10, Peutz-Jeghers. These are also associated with ovarian cancers. Okay. Then any other? What is the simultaneous risk of both ovarian and endometrial?
$10 to 15%.
Yeah, it's around 10%. Okay. So then any racial
synchronous malignancy rate.
Synchronous 5 to 10%.
Okay.
Okay. What about any racial predominance?
Ashkenazi Jews.
Yeah, they are but BRCA. So indirectly they increase. Okay. So what else? Yeah. Can you tell me whom will you see genetic counseling for ovary cancer? For whom you will do?
Anybody with a first degree relative or more than 2 second
genetic
degree
testing
relatives.
is mandatory for all ovarian cancers.
Okay. Yes.
All epithelial ovarian cancers, genetic testing is mandatory. Okay.
HRD testing.
Yeah. So, can you tell me some risk factors? For whom you will consider genetic counseling?
Anybody with a first degree relative having ovarian cancer.
Young age, bilateral.
Personal history of.
First degree relatives? There is age, no? First degree relatives with this much age.
Ovary, I think ovary, any age, their first degree relatives have to be counseled.
With you have to counsel, but what are the criteria?
Less than
ovary is mandatory, agreed. But what are the criteria? For whom? Any family history of breast cancer. Okay? Breast cancer with triple negative breast cancers. Okay? Or any family history of any epithelial ovarian cancers. Okay? At any age. Okay? Or any history of any pancreatic,
prostate.
BRCA related cancers, yeah, BRCA,
Male
adrenocortical,
breast
brain
cancer.
tumors, okay, all this thyroid cancers, okay, and male breast cancer. So these are the things that you will consider for genetic counseling. Is by risk reduction salpingo-oophorectomy standard of care for BRCA, and how much it reduces the risk for ovarian cancers?
Approximately 98 to 99%.
And breast cancer?
50%.
50%.
50.
And prophylactic mastectomy for breast cancers?
90%, ma'am.
90.
Yeah, it is at 90%. Okay. For here, it is BSO will give protection around almost 99%. Okay, 96 to 99%.
It is different for BRCA1, BRCA2, madam.
Sorry?
It's different for BRCA1, BRCA2.
Yeah, it is different for BRCA. Can you tell me any other genes apart from what we have discussed, Lynch syndrome, BRCA, any other genes?
BRIP gene, BRIP gene.
Yes. Have you heard of RAD51?
RAD51. Yes.
Yes, ma'am.
Yeah.
RAD51
Yeah, so
is
they are
responsible for this homologous
BRCA.
recombination DNA repair. So it is also play an important role in homologous recombination pathway. So it is one of the gene in the HRD.
Yes. So we already discussed about risk for infertility. How much? 2.05. Okay, like exactly around 2%. Smoking also is that much only. Okay, everything is around 2%. Okay, endometriosis, smoking, infertility. So yeah. So can anyone tell me something about the PLCO trial? What was this PLCO trial?
Prostate, lung,
Prostate,
colon,
lung,
and ovary.
colorectal, ovary trial.
It
for
showed
screening.
that CA125 does not have any screening benefit.
So other than colorectal, there is no benefit of screening, like in prostate.
Okay. Yes. So yeah. So next, we'll move to the examination now. I think we have discussed the risk factors and all. We have come to one diagnosis. So we'll move to the examination. Okay.
So on examination, I have examined my patient in a well-lit room with proper informed consent. General
Okay,
exam.
Saumyta, just
In
tell me
supine
what are
position.
salient points in this slide which are of importance in considering for your diagnosis, differential diagnosis. So we have
BMI.
only
Diagnosis.
BMI.
ECOG
I mean
score.
your differential diagnosis. ECOG. So what is ECOG performance status 1, 2, 3, 4?
European Corporate Oncology Group has defined performance statuses 1, 2, 3, 4. Patient is doing all activity without any strain, then 100% mobile. It is physical strenuous activities, ECOG 0. Patient can do all activity by himself but not strenuous, then performance score 1. 2 less than 50%, more than 50%, on wheelchair.
Less than 2. 2 is self-care. Patient is able to do self-care only and confined to bed less than 50% time of day.
50% of the time of the day.
It is completely confined to bed, not possible to do self-care, and 5 is dead.
Okay. So what has obesity got to do with ovarian neoplasms?
Obesity is one of the risk factor for adnexal mass, especially endometrium.
What is its relation to ovarian neoplasm?
There are type 1, type 2 ovarian neoplasm ना मैम, पता नहीं इसी का था कि नहीं. Avneet.
I think it can cause infertility and that way.
That is in endometrium.
Yeah.
Yeah. Tell me what is relation of obesity to ovarian neoplasm?
can it be associated, like it can cause infertility and then the treatment can increase the risk? Or peripheral estrogen something to do, like I'm not sure, ma'am, but obesity generally
Increase the risk mostly.
So it is same like breast only. So postmenopausal obesity will increase the risk. Okay.
And
So due to
premenopausal.
peripheral aromatization. Then what else? What is important?
weight loss may indicate metastatic or Krukenberg side, but it is not like reproductive.
Okay.
Body surface area in this
Needle edema.
for
Needle edema.
treatment part.
Okay.
It should be
So,
according to breast only, no?
so something related to pulse rate to your patient, she had an acute episode. Okay. So that's important. Then yeah. So respiratory pattern is important.
Thoraco-abdominal. No, अगर
yeah, thoracoabdominal.
अगर ascites है या abdominal mass है तो क्या होगा?
Labored breathing will be there. Difficulty in breathing.
Abdominothoracic, thoracoabdominal.
It should be thoracoabdominal only, ma'am, but then labored breathing will be there.
Pallor, how is it related?
Pallor, maybe there is no history of bleeding, but then it can be
internal
associated
mass hemorrhage can also be there, ma'am.
Yes.
Yeah.
So they are all related to some hemorrhage and planning of your treatment, right? So
Yes.
jaundice also, it can present with some metastasis, all these things. Okay, edema and all are nutritional. Okay. Supraclavicular lymph nodes.
Metastasis.
Next, inguinal lymph nodes.
Inguinal lymph node, pelvic lymph node enlargement.
Inguinal lymph nodes in ovary.
Stage 4.
Okay. Pelvic lymph nodes.
3C1.
Retroperitoneal lymph nodes.
3C2.
2.
Okay. In ovary.
More than
In ovary,
2, less
it is
than
3A1,
microscopic.
A2.
Microscopic
So
3A1.
that's stage 3. Okay.
Yeah. 3A.
Less than
That's
2
stage
centimeter 3B and more
Stage
than 2
3.
centimeter 3C.
Node.
Node नहीं, deposit.
नहीं वो deposit है.
Largest.
So, yeah.
बोल भाई
So then
दिव्यांश,
breast-
ये तो ओवरी की
So
thesis है.
always remember whenever you get your adnexal masses, thyroid or breast, you have to describe all these things. Okay. Even any female lady with breast mass, breast lump or abdominopelvic mass or a thyroid swelling, don't forget to describe breast and pelvis in them. Okay, if you get a thyroid, if you get a breast, thyroid and the pelvic mass. Okay, if you get pelvic mass, breast and thyroid. So all this have to be included. Okay,
Why thyroid?
why thyroid? You tell me.
Cowden syndrome.
Cowden. So any palpable lymphadenopathy. Next. So he ruled out other system. Okay.
Ma'am, इसमें
So now-
in the last slide they've written respiratory examination NAD. उसके पहले भी wrote thoracoabdominal respiration.
Thoraco.
She did not.
In female it is normal, na? In male it is.
It is normal, na?
Okay. ठीक.
So okay, forget about this. Okay. So just go to that page with the picture. So one of you take a lead. Anyone who is attending, take a lead and present. On inspection, what you will see. On palpation, what you will see. On percussion and auscultation, what you will see. And something else.
Drishita presenter
Decide.
present.
Patient exposed from basically clavicle to mid thigh under natural light in supine position. Distended abdomen noted. Umbilicus central. Fullness noted, occupying most of the around the umbilicus, and I don't know. I think it's reaching up to the umbilicus picture.
Okay, you tell whatever you see. Okay, we'll change, no problem.
Yes, fullness noted occupying the bilateral pelvic and also reaching up to the umbilicus region. What is that? Melanotic lesion noted in the.
It's a nevus.
Ma'am?
It's a nevus. It's a nevus.
Okay, nevus, nevi noted in the umbilical region, 2 centimeter above the umbilicus to the right of almost 1 into 2 centimeter. No scars, no sinuses, no dilated veins noted. And
Hernial orifice appears to be normal.
orifice is intact.
And
Movement with the respective quadrant.
Moving equally with
corresponding quadrant move equally with respiration. Okay,
Here
fine.
it won't be moving, no, ma'am, because I think because of the mass.
Yeah. And what else you will examine? You didn't finish abdominal examination. Abdominal still?
इंस्पेक्शन ही बोला है अभी.
इंस्पेक्शन में कुछ और भी देखोगे ना? Can it be renal?
Fullness of renal angle.
No flank fullness, renal angle, no fullness, bilateral renal angle.
Anything else? So if you are examining an abdominal pelvic mass, so anything else you would like to touch?
No fullness.
So 2 ways of telling. Either later you can tell external genitalia examination, or you can tell it here only. Okay, on inspection. Both.
Yes.
Ways are accepted. Okay.
Yeah.
So yeah. Now
Later on palpation, no local rise of temperature, no tenderness. Mass of almost 15 into 20 centimeter felt. 15 into 20 centimeter felt occupying the hypogastrium, right iliac fossa, left iliac fossa, and reaching up to the umbilicus, with borders felt superiorly and the lateral borders well felt. Inferior border could not be well appreciated, with smooth surface, firm in consistency, restricted mobility and limited mobility along mediolateral. Restricted mobility accordingly and mediolaterally, limited mobility noted. Now,
you are saying only mass. What about the rest of the abdomen?
And no hepatomegaly, no splenomegaly, no mass felt
organomegaly to be the safe.
no organomegaly. And further on percussion, the mass was the size of mass confirmed, dullness noted over the size of the mass, and liver span of almost 14 centimeter. No ascites.
Mass characters, I think, like consistency. If we can appreciate.
So last time also I told. So you should tell the superior border, inferior, if you are able to feel the lower border, or what is your lateral borders. Okay, which quadrant it is occupying. Some people accept the way of telling this period of gestation if it's an abdominal pelvic mass, but some don't. Okay, so depending on your examiner, you just tell.
And we are not aware also, ma'am, quadrant gestation ka
yeah, it's fine. So describe the superior border, inferior border, and the lower border is not felt, and medial and lateral border, then it's fine. Okay, and surface.
Surface consistency,
smooth surface,
mobility,
firm in consistency, restricted mobility in the transverse axis.
I think in ovary we have to say variegated consistency.
Not necessarily.
No, ma'am, because it's huge mass, na. It's not the same all the side.
Not necessarily. Whatever you feel, you can tell. Okay. Tense cystic mass can appear. Okay.
Yes.
So, whereas cystic solid mass can appear, as we told, variegated. So it's not necessary that always it is variegated. Whatever you feel, you tell. Okay.
Yes. And distance of the superior border is almost 10 centimeter from the epigastrium, sternum, and laterally, right side almost 3 to 4 centimeter from the ASIS. Then the left side, the low lateral border is almost 3 to 4 centimeter from the left ASIS. Inferior border could not be well made out, and no organomegaly, renal angle, no fullness noted, no palpable.
So whenever you start, no, you say which quadrants of abdomen it is occupying. Okay, so that gives a rough idea. So suppose when you're telling, no, examiners will imagine in their mind. So without seeing your paper, okay, so they should get a clear picture with your description. Okay, you should tell it in that way. Okay.
Should we mention, ma'am, like so after voiding of urine, we examine like that?
That you can mention. Yeah. Yes. Again, renal angles and hernial orifices, regional lymphadenopathy will confirm. Okay.
Yes.
Next. So that was the mass to describe.
So मैम quadrants of lump from mid clavicular line का vertical line है, horizontal line transpyloric plane है, at the level of L1 है. अगर ये कैसे बताएंगे तो from Ziffy sternum to umbilicus का जो mid point रहता है that is transpyloric plane if L1 हम identify नहीं कर सकते हैं तो, and transtubercular plane 5 centimeter distal to the ASIS.
Ninth costal cartilage.
Ninth costal.
Next.
Transpyloric जनरली वही रहता है ना.
मैंने ऐसा पढ़ा था कि दास में उसने ऐसे मेंशन किया था.
Umbilicus can be varied in position due to some lower abdominal mass. It can be like moved side like that.
ठीक है. Ninth costal cartilage.
On percussion, we have to mention renal angle percussion also, no ma'am?
If renal angle fullness is there. Okay.
Ma'am, liver percussion we have to do in all.
Yes.
Liver span.
So liver span we are measuring from mid clavicular line from fifth costal cartilage, no?
Fourth intercostal space onwards, we start doing the percussion in the mid clavicular line till the lower point of the dull point that is heard, and total distance is usually around 12 to 14 centimeter normally.
Yeah.
Mid clavicular. Yeah.
So now you tell external genitalia.
External genitalia on examination, vulva, labia majora, minora and clitoris appeared normal. Periurethral region was normal. No lesion or mass seen protruding from the vagina or
perineal.
First, I think, ma'am, we have to mention hygiene. ऐसे नहीं होता क्या? ओरल कैविटी में तो होता है.
Generally you don't. If you want to mention, again they shouldn't go to trichomonas, chlamydial infection. So don't utter something which you don't know. So better.
And on inspection of perineum and perineum, the skin surrounding the perineum was normal. No fissures, no fistulas, no sentinel tags noted, skin tag or warts noted, no genital warts. And on further inspection of PV and perspectillum, per vaginal inspection, no growth felt in the vagina. Bilateral fornices, fullness is felt. Cervix was normal, no growth felt, and on bimanual examination, there was restricted mobility of the mass that is seen, but bilateral fornices appeared full. And per rectal examination, sphincter tone is normal. Gloved finger stained with normal colored stools, no mass felt, no deposits felt.
Fine. Okay. So based on still what anything else?
Yes. After this, we would like to examine the musculoskeletal system. No spine tenderness, no bony tenderness felt anywhere. And inguinal region examination, no palpable groin nodes felt, and supraclavicular lymph node, no supraclavicular lymph node palpable or fullness.
Yes. So do mention. Don't take the risk. Even if you mention in general examination, supraclavicular is mandatory. Okay?
Yes.
Ma'am,
Yes, fine.
this we have mentioned back pain because she has said back pain in history, or as a rule in any abdominopelvic mass we have to
All
mention back.
abdomen patient.
All abdominopelvic masses you should tell back. Like
Abdomen
history
and
of back
breast also, I think.
Yeah, like
breast is bone pain. Okay? So mainly breast is bone pain. For abdominopelvic, back pain. Okay? Then
Ma'am, what is it like in examination? Cervix pulled up, when we should say it?
cervix pulled up.
When like what? I have never seen. Like I have not done much gynec posting. So what does it mean? Cervix pulled up. When we should say?
When the cervix is high up and we are not able to feel it.
We are not able to see it on PS, then probably we'll tell that, but cervix is pulled up.
And it has any
Generally,
relevance?
it is seen in like this PID, pelvic inflammatory disease, wherever there is chronic inflammation. So we'll not be able to characterize it through PV or PS. So that time we'll tell.
Okay.
Yeah.
Ma'am, what will be the importance of back pain in abdominal and pelvic cases?
So what all abdominopelvic masses can present with back pain? So you take genitourinary system, okay? So in genital system, huge fibroid, okay? So huge fibroid or any huge masses that are compressing on the nerves. So they can cause referred pain to or low back pain, okay? So even endometriosis can present with chronic low back pain. They can present with some neurological, either back pain pathology can be neurological, or it can be due to metastasis, or it can be due to some nerve infiltration per se, compression, infiltration, or metastasis. So all these masses can present with back pain.
Okay, thank you.
Yeah. So summarize your diagnosis, Dishita.
इसने हिस्ट्री आई थिंक
So,
नहीं सुनी है मैम.
your-
हिस्ट्री
Sorry?
सुना था क्या पूरा?
Okay, fine. So I'll summarize it for you, but you tell me complete diagnosis, okay? You should tell me complete diagnosis. Don't tell like ovarian CA like that. You shouldn't tell, okay? So she's a 50-year-old premenopausal lady who presented with pain abdomen with one episode of acute onset pain. Then she has been having this pain for the past 6 months, not relieved with any other conservative measures, and she of late presented with some compressive uropathy symptoms with straining to pass urine. She has no other contributory family history, any history suggestive of distant metastasis. On examination, there is a mass that is occupying the hypogastrium umbilical regions, okay, and with restricted mobility. Did you tell bimanual palpation? Dishita only presented, no? Did she tell bimanual palpation?
Yes, ma'am. Yes, ma'am.
So restricted mobility on bimanual palpation also. So what do you infer if it is restricted mobility? What do you see on bimanual palpation?
Basically, we palpate through the abdomen and through the pervaginal, and first we see if the mass is felt in the fornices, bilateral fornices, and then we check if it is mobile in
mass.
the
Is there any fullness of the fornices?
Fullness of
mass
the
will not be felt through fornices. Okay, it will be fullness. Okay, next.
Yes. And it is felt separately from the uterus.
I have a doubt. Do
So
we
how
do it
do
like
you-
once in the abdomen, one hand on the abdomen and pervaginal, or do we do PV and PR together?
नहीं
Put
नहीं
one
नहीं,
hand
that
on
is
the
different.
abdomen
PV and PR, when you are doing together, you are seeing parametrium.
That is 2 fingers. This
That
is
is
one hand
bi-digit.
in the.
Bidigital.
This is doing a PV with one hand in the abdomen, over the abdomen. Okay. So you try to move the cervix and see the relation of, you see the mobility of the mass in relation to the movement of the cervix. So whether it is moving with the cervix or it is separately from the cervix. So separately, see, most of the masses may not be, typical ovarian masses also may not be felt separately from the uterus, not necessarily. Okay. So sometimes uterus is felt separately from the mass, and on movement of cervix, this mass is moving independent of movement of the cervix, or this mass is moving along with the cervical movement. So that is what you should tell in bi.
Ovarian mass will not move with the movement of the cervix, right, ma'am?
It will move ना, कभी-कभी move करेगा ना, उसका तो अलग है.
When it is huge, in contact with the uterus, and uterus is not felt separately, it might move. Okay, not necessarily that it shouldn't move. Okay, there is no hard and fast rule. Okay, but this is what you generally look for. Okay, then
Ballotment.
yeah, ballotable lower border is not felt, she told. Renal angles are free. So you can add a sentence saying it's not ballotable or bimanually palpable, not felt in lateral decubitus, just to rule out a retroperitoneal mass etiology. Okay.
And for adnexal, we mention like that we like. I think I'm
generally they will not be ballotable.
मैम हम लोग ने वो नहीं किया, हम लोग ने leg raise test नहीं किया.
External ballotability and internal ballotability will be there.
मैम leg raise test करेंगे ना इसमें?
You will see, in which plane, whether it is intra-abdominal or it is parietal, same. You have to do all those tests. She missed saying it.
Ballotability can be also mentioned. I read in the book they were
external and internal ballotability. Yeah,
PV
there is difference
ballotability
between
also.
external and internal ballotability. Okay, so renal masses have external ballotability, whereas genitourinary masses have internal ballotability. Internal ballotability in the sense, that's what I told you now, cervix and moving the mass. So that is internal ballotability.
So ma'am, all intraperitoneal mass leg rest test में they will we will not able
generally,
to palpate.
The lower abdominal masses are tested by leg rising test. Upper abdominal masses
head
by
rest test.
Intraperitoneal or retroperitoneal also.
इंट्रापेरिटोनियल में तो नहीं आएंगे वो.
That is peritis. Okay. So rule out peritis and intra-abdominal masses.
Intraperitoneal.
Okay. Whereas retroperitoneal masses are by lateral decubitus or new elbow position. Yeah.
Should we mention knee elbow? Like I have heard, sir, with sir.
No.
Knee elbow कभी नहीं कराते.
Sir, if they probe and ask you what else was there which is not done now, then you mention knee elbow. You tell lateral decubitus, you will be safe. Okay. So
yes.
Then so tell me full diagnosis. Don't see this and tell. Rishita.
Oh, yes, ma'am. So 50-year-old premenopausal Paris patient present Paris patient with a probable diagnosis of a abdominopelvic mass, which I would like to give a differential diagnosis as either a tubo-ovarian mass as my first diagnosis, and
continue. No issues. Can it be a retroperitoneal mass still?
Yes, ma'am. It can still be.
Can be. See, though lower border is not felt, still it can be. No issues. Okay, you can give retroperitoneal masses on diagnosis, but lateral decubitus, it is not. It is more felt on PV examination, so it goes against it. So in tubo-ovarian masses only, so either you can give first diagnosis, most likely an adnexal mass. Okay. So what is adnexa, Dishita?
Ovary, fallopian tube, and the connective tissue around it together form the adnexa.
So what all differential diagnosis can be here? Most likely you are thinking this is malignancy or benign.
Considering her age and a symptom of 3 months and with large mass, I would think of malignant mass as my first, though it could be benign as well or a low grade.
Yeah.
If there is any other associated mass in the abdomen is what I would like to look in, and if it is a mass, is a solid cystic mass or a purely cystic mass or a complex cyst is what I would like to see. And along with it, I would also like to get tumor markers CEA, CA125, beta HCG, LDH, alpha fetoprotein in this patient.
So, wait. So there's a lot in ultrasound and imaging that we should discuss, okay? So, you would like to do an ultrasound as your extension of clinical examination. To confirm your diagnosis, what will help you?
To confirm my diagnosis, first in this ultrasound, I would just like to see if it is a mass, where is it originating from, and is it a cystic or a solid cystic or a complex cyst, and if there is ascites, and also look to evaluate other structures like the liver, kidney, ureter, with relation with the ureter and the uterus, if there is any associated fibroid mass or it.
So, relation with the bladder, relation with the rectum, nodes, ascites, other organ systems, as well as to characterize the mass. Okay. So, these all things can be done. If you find ascites and all, you can do intervention also with any omental deposits. Some deposits you have found, not ovary. Okay. But still, if you feel it is advanced disease, at this stage, see, somebody asks you, why ultrasound? I'll do a CT directly.
If I find in ultrasound, if I find a complex cyst or a solid cystic mass and also ascites with few deposits, then I would also like to do a ascitic fluid for cytology or cell count, or even a biopsy from the deposit at this stage itself. So that would help me to further plan my treatment as well.
So somebody has done a ovarian biopsy. So what's your this one take on it?
Ovarian biopsy. Ovarian biopsy usually should be avoided because it upstages the disease. In a patient who doesn't have any ascites, or if the patient doesn't have any peritoneal deposits or anything, so that it becomes 1C2. 1C2.
1C. Okay. So yeah. So now you tell me, like we have discussed, what are the to characterize benign and malignant masses on ultrasound? What are some indices that are available at Nexel masses के लिए?
Iota, simple rules, iota adnex.
Yes, Roma score, ACR ORADs.
USG.
RMI.
USG,
so what is
ACR
Roma?
ORADs?
RMI is there, ORADs is there.
So okay, fine. Suppose you have a malignant mass, whoever is it. Rakesh is there, no, online. So just tell me, Rakesh, what are the features of a malignant adnexal mass?
Malignant, my first, it will be like size more than 10. Like there are 5 points in complex M1 to M5. So these are like more than 10 centimeter, multilocular with large septations, solid mural nodule more than 7 mm, and more than 4, and ascites, and bilateral masses. But bilateral is not there.
If there is any associated lymphadenopathy or ascites or any other nodules. So irregular, nodular, solid cystic masses more than 10 centimeters with bilaterality with ascites and any other features of lymphadenopathy or metastasis.
Yes.
Yeah, color scoring. What is the scoring?
More than 4 is towards malignant.
Okay. So, somebody was telling iota. Okay. So, what is iota?
Iota ORADs was given by...
What is iota?
International Ovarian Tumor Analysis. International Ovarian Tumor Analysis Group.
What?
International Analysis Group, I think.
What? International
ovarian tumor analysis.
मुझे तो कुछ एडेनेक्सा याद आ रहा है.
Iota adnex is there. Iota adnex. Adnex is assessment of different neoplasm of
What is ORAS? What is ORAS?
ovarian adnex reporting and data system.
Yeah. So IOTA is International Ovarian Tumor Analysis, and ORAS is Ovarian Adnex and Reporting Data System. So what are the M and B rules?
IOTA had three kind of modifications. First was simple rules method, then was logistic regression method, then was ORADs. First, when it was simple rules method, there were 5 B rules and 5 M rules. And
Yeah. Can you
they
tell
had
me
to be
5 M rules
exclusively
we have discussed? Solid, multilocular, more than 10 centimeters, and increased blood flow with capillary projection is additional. Okay, what are B rules?
Ma'am, no blood flow, unilocular cyst. If multilocular cyst, then less than 10 centimeters. If solid component, then less than 7.
Nodule less than 7 mm.
How much? Yeah, less than 7
Less than 7 mm.
7 mm.
And less than 10 centimeter. Less than 10 centimeter.
Or any acoustic shadowing. Okay. So these are
no
the-
ascites.
Yeah. And what is ORADs में क्या है?
Ma'am, that had ORAD 0 to 5. ORAD 5 being highest risk of less than 50%, more than 50% risk of malignancy. And 10 to 15 ORADs 4, 1 to 10 in ORADs 3, less than 10 in ORADs 2.
Less than 1 in ORADs 2.
Less than 1. So, can you tell me ultrasound uses, like if you're asked 3 uses of ultrasound, okay, and 3 disadvantages. So, what is your answer? 3 uses.
Site is organ of origin.
First, tumor characterization, organ of origin.
Yeah, that is okay. But what are the advantages and disadvantages?
Characterization. It
Solid
tells the
and
origin of
system.
tumor, the characterization.
You all are talking about tumor characterization. I'm asking advantages of ultrasound. It is cheap. It is widely available. There is no radiation exposure. Okay, these are advantages. What are disadvantages?
Lymph node cannot be
Operator dependent.
Yeah, it is operator dependent. And staging is not possible to a great extent. Okay. So, and what about somebody has asked TVS. So, what is the sensitivity and specificity increase if you add TVS to TS or the individual TS and with a Doppler?
TVS
you can
is
tell
good
some
for
random this one. I'll correct you. No problem.
TVS, ma'am, like it is good for screening average risk or high risk patients.
So, अगर TVS और abdominal ultrasound मिलाया जाए तो sensitivity will be around 90%. Okay, specificity will be 80%. Whereas if you do a Doppler with the TVS and all, so it will be around 85%. So individually TVS will not be very much beneficial in abdominopelvic masses, especially of ovarian origin. Okay, what is the sensitivity of CT? It's sensitivity. Okay, you can tell me simple answer. Which is more specific, ultrasound or the CT?
for mass USG.
I'm asking specific. Which is more specific, which is more sensitive?
Specific CT.
Sure.
I think for excluding the diagnosis, we need CT.
So CT is more sensitive. Okay. CT is less specific than ultrasound. Ultrasound is very good for characterization of ovarian masses. Something which is like doubtful in an ultrasound or CT to characterize more of benign mass origin masses. MRI is helpful. Yes.
Yes.
So you should tell that benign masses. अगर benign दिख रहा है तो MRI is helpful. Okay. So what about PET?
For recurrent.
What is role of PET in ovary?
Unequivocal findings on CT or other imaging and recurrent setting.
It is in a metastatic setting generally to see the response. Okay. Otherwise, it has very less sensitivity and specificity compared to any other investigations. Okay. So that's about Now coming to what do we say? Blood. So what do you want to see on blood investigations?
RMI पूछेंगे क्या मैम?
Sorry, I forgot. What are the indices? Roma, RMI.
RMI that अपना USG findings,
Menopausal status.
Yes.
And into level of CA125.
Okay. Ultrasound में कितने points हैं?
1 and 3. If there is if there is no suspicious finding, then it is 0. If there is no suspicious finding, then it is 0. If there is one suspicious finding, it is 1. If there is more than one suspicious finding,
2
it is
to
3.
5 suspicious finding, that is ultrasound score of 3. Okay. So menopausal status?
1 and 3.
Premenopausal 1, postmenopausal 3.
Correct. CA125?
Exact level, whatever the level, the score more than 200 is more towards malignancy.
That is RMI, total score.
Yes.
Okay.
Yes.
So, what is sensitivity and specificity of this RMI? Is it more specific or more sensitive?
Sensitive.
Sensitive it should be.
Do we use RMI or Roma and we don't use?
USG is better.
RMI should be used by a general gynecologist to decide the referral.
Yeah, so it should be more specific, right? So its specificity around 85%. Okay. So what about Roma?
Roma is
for screening.
Yeah, tell me what are the components, like what you consider in Roma?
CA125, HE4 and menopause status.
What is the HE4? What is HE?
Yeah, human epithelium has 4 proteins.
Okay. So if HE4 is raised, so what is your take on it?
Mostly serious malignancy.
HE4, like for pre-menopausal patients, CA125 is not much sensitive. HE4 can help in doubtful cases. Post-menopausal, line CA125. Then HE4 being more specific. Yes.
Yeah.
We can use.
So, yeah. So, other than this, okay, now coming to the markers. Tell me something about markers in ovary. Ovary. I'm not telling ovary and CA.
LDH, AFP and beta HCG.
Yeah, tell the tumor, tell the marker, tell the age group.
Beta HCG for dysgerminoma.
Beta HCG for choriocarcinoma.
So, each of one of you tell one. Okay. First, Avneet, you tell. Avneet, tell one.
Yes, ma'am. Ma'am, in embryonal, mostly all of them will be raised. AFP, beta HCG, LDH, almost all will be raised.
More specifically raised in embryonal?
Alpha
HCG.
fetoprotein.
Alpha fetoprotein. Okay. Any specific things that you see in embryonal? Any bodies?
Schiller,
Carl Exner.
Schiller, all bodies.
नहीं वो तो भाई उसमें
Carl Exner is in this. Somebody told Carl Exner. Carl Exner is not in embryonal.
In embryonal, there is risk of lung mets.
It's in granular cell tumor. Okay. Yeah. Embryonal.
Lung mets risk is there.
Yeah. So embryonal, he told. What is the age group of this germ cell tumors?
Ma'am,
Third, fourth decade.
Sorry?
Puberty.
Third, fourth decade में.
Adolescents
Younger age.
also and 50s also, ma'am.
Yeah. So generally younger age. So some of them have bimodal presentation, like the granulosa cell. Okay. So now next, Rakesh, you tell one tumor. Tell the characteristic feature and
CA1 epithelial ovarian.
okay, it was the easiest one. Tell.
So it is used for epithelial ovarian cancer, and age group being 5th, 6th decade, most common age group. And
So now since you chose the easiest one, I'll ask you, what is the normal CA125 level? What is the unit?
less than
प्रीमेनोपॉजल में कितना है, पोस्टमेनोपॉजल में कितना होना चाहिए? What is the CA125 to CA rate का imply?
So less than 35 units per ml. And
something does it differ in premenopausal and postmenopausal?
Yes, ma'am.
It's significantly increased value. When do you say?
So premenopausal is less sensitive.
35 is normal. Okay, accepted. Next. When is it in premenopausal? You call it is increased. When is it in postmenopausal? What is the value?
More than 200.
More than 95 in premenopausal and more than 35 in postmenopausal.
Postmenopausal is 35. Premenopausal.
What is the unit?
Units per ml.
What is the alpha fetoprotein unit?
Nanogram per ml.
Navneet, you told, no? What is the alpha fetoprotein? What is unit of TSH?
International.
Microgram.
International.
Milli international units per liter.
Units you have to remember, okay? TSH, alpha fetoprotein, beta HCG, okay? LDH, okay? All this you have to remember the units. Very important. Okay, they'll ask you. And yeah, for CA125 it is international units per liter. Yeah, then what is the significance of CEA to CA125? CA125 to CEA, Rakesh?
Ratio tells, especially in mucinous, if there is mucinous case and we are having some doubt. So ratio of more than every ovary case we can use it. If it is more than 25, it is more towards ovarian origin. Less than 25, it is not extra ovarian.
Yeah. Next person. Who is that? Saumyta. Yeah. Tell one unit.
Granular cell tumor inhibin.
Granular cell. Inhibin A, B?
B.
B.
One is used for infertility, one is used for ovarian tumor.
B for ovarian, ma'am. A for infertility.
Yeah. So what is the you are telling granulosa cell tumor. So how do you, which age group?
Ma'am, it has bimodal presentation. And yeah, this granulosa has peculiar feature of bleeding, ma'am.
Virilization.
Yeah. Bleeding
TV also.
Yeah, bleeding. So next is Mohit. Tell Mohit. One, this one?
LDH is also used. Marker of tumor burden.
Yes. LDH is not very specific marker, it's marker of tumor burden. So what is the unit for LDH?
Unit per liter.
Sorry?
I don't know, ma'am. Units for LDH.
Anyone else?
It is some international unit per ml, I think.
Yeah. Same. Okay. Then Anuradha. Tell ma. Next. Anuradha, you're there?
Yes, ma'am.
Yeah, tell. Jaldi बोल रहा है. We have to request. Management.
Sorry, ma'am. The question, ma'am.
No. Any one tumors, marker and its normal value and age group.
Yes, ma'am. I'm not able to.
Ma'am, beta HCG only left, ma'am. Beta HCG only left for
Alpha
choriocarcinoma. Alpha fetoprotein already covered, na. Choriocarcinoma and reproductive age group.
Ma'am, dysgerminoma, PLAP, placental.
Plap, so testicular.
So PALP and LH both.
Yeah. What about the Brenner tumor? What is Brenner's tumor?
Transitional cell tumor of the ovary is also known
Is
as
it benign or it is malignant?
Benign.
Can be malignant, can be borderline.
Mostly it is benign. Okay. So yeah, next. So HCG. Okay. Fine. These are serotolinic cell tumors.
These are sex called straw.
Yeah. So age group?
Adolescent.
So these are the most common like non-epithelial tumors that we have discussed. So in epithelial, what is the types of epithelial ovarian tumors?
Serous
High-grade, low-grade, borderline.
cell. Serous mucinous.
High-grade serous, high-grade mucinous, endometrioid, clear cell, Brenner, malignant.
Serous, mucinous, endometrioid, and clear cell, and squamous. All are divided in benign, borderline, malignant.
Yeah. Clear cell also is that. What is specific to clear cell? Only 1 point.
Poor prognosis. Aggressive.
They are resistant to platinum-based therapies. Okay, generally. And you see ARID1 in them. Okay, ARID1 PIK3 mutations.
And non-secretors also.
Yeah, they generally present with metastasis, as you told, and poor prognosis. And they will be associated with this paraneoplastic syndromes. Okay. Yeah. So what about high grade and low grade? So what are the mutations associated with high grade and low grade serous tumors?
P53 mutation.
P53, HRD, all are high grade.
And what are the treatment options for high grade serous tumors?
We are using, ma'am, bevacizumab and olaparib.
So, yeah, PARP inhibitors generally, and they're sensitive to platinum-based chemotherapy. Okay, yes. But most of them will present with advanced stage. Okay, TP53, BRCA, these all are more common with them. Low grade, mein, what do you see? What mutation?
KRAS.
BRAF can be.
KRAS, I remember.
KRAS, correct? KRAS, BRAF, all these mutations. Okay. And they also have this low-grade serous carcinomas.
In this,
they can be treated with hormonal
therapy. And hormonal therapies are useful.
Hormonal therapy and this, what is that, MEK inhibitors. Okay, so then what about mucinous carcinoma? What is the mutation?
Mucinous, MSI.
Generally with KRAS mutations. Okay. And they present with younger age groups. Early age groups. Okay. And they also are not very sensitive to chemo as any other mucinous CS. Okay. So that's about pathology and hematological.
In this, I think, ma'am, they have mentioned that they are giving मतलब जो GI का drugs देते हैं ना, they are giving that drugs only for this patient.
So because they're more common, no? Like this is where you see CEA. Yeah. So yeah. So any studies about the CA 125 raising, non-raising? Can anyone quote any study?
CA 125.
There is a study regarding when they screened few patients and they created a spectrum and rising CA-125, they whenever they had a rise in CA-125, they kept the patient for TVS, and they were able to identify patients at a lower stage. But that's not in the full. It's not approved as of now. But any patient who has at a higher risk, they usually screen with CA-125, and the one on the rising trend they take for TVS. I don't remember the name of the
Eligibility criteria of United Kingdom familial cancer screening study. More than 10% lifetime risk of ovarian cancer, younger age less than 35 ईयर और जिनका RRS नहीं हुआ है, तो एक रोसेंथल एट ऑल फेस 1 ट्रायल है, उन्होंने बोला
रोका स्टडी. आई नो.
Yeah, okay. Right. So what is importance of HE4? You already told it is expressed in almost all serous endometrioid. So this it's more if HE4 is there. So it is used for what? HE4 monitoring.
More specific.
Recurrence, ma'am.
Yeah, recurrent. Very important.
Is not elevated.
Recurrent or progressive advanced cases it is used. Apart from this, you know any other markers? So there are other things like other non-specific markers like CA 15.3, 19.9. All these also can be raised in some of the ovarian tumors. Okay. So then yeah, रोमा में कितना है कि वो जैसे RMA में 200 है, so रोमा में कितना है high risk premenopausal postmenopausal?
Premenopausal 7.4, postmenopausal I think 15.3.
What I remember is 13 and 27, but just check it once. Okay.
Okay.
So yeah. So then, what about yeah? What are the exclusion criteria for Roma? For whom you cannot do Roma?
Exclusion criteria.
So who are less than 18 years of age, who had malignancy before, or currently on treatment for malignancy, pregnant women, you cannot use Roma. Okay. So, and any cytokeratins that you see for in ovarian tumor?
720.
What is CK720? What is the change with ovarian?
CK7.
Which is for bowel, which is for ovary?
20 is for colorectal.
सीड सब 2 and 20 था ना कुछ डॉक्टर राकेश?
7 and
No, it is CK720. I am telling no. This is for
7 and 20 both positive in ovary, breast, lungs.
No,
CK7 is positive in what?
No, 7 positive, 20 positive. Both are positive in breast, ovary, lungs.
No.
Breast, endometrium.
No, if you are asked which is more specific to bowel, which is more specific to ovary.
colorectal.
20 and CDX2 for colorectal.
7 is more specific.
8 for ovary, ma'am.
No, 7 is more specific for
WT1 also.
Yeah.
Yes,
Yeah. What are the other markers in IHC that you want to look for? Anything else? So you told flap in dysgerminoma. Okay. You told anything else? What is for embryonal cell?
HCG.
Have you heard of OCT3 and OCT4?
Socks, one socks
Yes,
is
yes.
also
So
there.
they are raised in embryonal cell, OCT3, OCT4.
OCT3, OCT4.
OCT.
Sorry? Yeah,
Some
OCT3,
CDX,
OCT4.
CDX2.
Okay, alpha fetoprotein we discussed.
Yeah.
Yeah, CDX2, SOX2, all this SAL4, all this are for ovary only.
I think SLL4 जो है ना मैम वो भी बहुत जगह पर आते हैं.
Yeah, SAL4. SAL4 is like more for like embryonal cell carcinomas and choriocarcinomas. Okay. So yeah. So what else? In pathology, did we leave anything? Yeah, I think we discussed pathology. Now we discussed ultrasound. Now come to CT. What additional benefit you will get by doing CT. We already discussed sensitivity and specificity, so I'll not go in that.
Lymphadenectomy, lymph node status, ma'am.
Are there any CT criteria that you know of?
Bristow. Bristow score.
Yeah. And
Some with S.
some metal. What is that?
I'm not able to recall, but it's start with S. Saumyta something.
Sudan. Okay, Sudan metal. Okay. Then yeah. So what are the anything else apart from CT or MRI, PET? What we discussed. Anything else in ovary that is very important? हर किसी ovary case में suppose you do something, okay, apart from the blood investigations and all, to see the burden of the disease.
Diagnostic.
Yeah.
Staging
You
lab.
call it diagnostic or staging?
Staging lab.
Yeah. So what do you want to see on? First we'll complete off the CT characteristics. So CT also, what additional things it will give you apart from what we discussed in ultrasound?
Nodal and distant mets.
Okay. Nodal characterization is better with CT. Okay. So yeah. MRI we discussed already for benign masses. Okay. So tell me what you want to see in laparoscopy. And what is the scoring? Any scoring you are aware of that, please?
Phagotic.
Yeah. What is laparoscopic predictive index scoring? What all you look for?
Basically, peritoneal carcinomatosis and intestinal, we will.
Peritoneal carcinomatosis, 1. There are 7. You tell me 1. 1 is peritoneal carcinomatosis. Then?
Diaphragmatic deposits.
2.
Mental deposits or caking.
3.
Stomach. Small ball deposits, stomach deposits.
A site is more than 500 ml, para-aortic lymph node less than
That
1
is not for
centimeter,
phagotic.
infrarenal
No,
more than
no,
2
no, no.
centimeter, suprarenal.
No. What you are telling is not laparoscopic predictive index.
That is ma'am inoperability criteria.
Yeah.
Mesentery. And
Mesentery.
liver, I told liver.
One more is there.
Liver.
7. Yeah. So this is about. So this were again modified. Original Fagotti had all this criteria. Okay. Again in modified, they have removed some. Now what modified has? Out of what you told, only 4 are there. Modified Fagotti score.
Okay. So I'm not aware, ma'am, but peritoneum should be there.
More than 2 centimeter back lesion, more than 2 centimeter pelvic mets, more than 2 centimeter suprarenal disease, and more than 500 ml of acid.
So modified Fagotti has diaphragmatic disease. Out of what he told, only they're there. Okay. Out of 7, they have removed 3. So it has only 4. That is diaphragmatic disease, mesenteric involvement, stomach, and liver mets. Okay. Rest of the things they have removed. Okay. So what are these advantages and limitations of the Fagotti score?
Advantage, so ma'am, we can decide whether we should go for primary surgery or chemo first. Disease burden we can assess. Basically, PCI we can see.
Yeah. So, but limitations is that you have to do it under, it's a surgery, so you have to do it under TA. Okay. So, difficult to assess. What are the hidden areas in ovary? Difficult to assess.
Caudate lobe of the liver.
Okay, retrohepatic state.
Retrohepatic. Then mesenteric deposits.
Lesser sir.
Retrohepatic, retroperitoneum, and porta hepatic.
Root of mesentery we can see, ma'am.
Route of mesentery you can see. Okay. So, but very difficult to assess a porta hepatis, retroperitoneum, and retrohepatic space. Okay. Then, yeah. So, there are some other things that this laparoscopic risk scores are there. So, one is Fagotti. Then, any other things? To tell the introp assessment for tumor burden.
PCI.
LAT scoring.
Yeah, LAT scoring. What's LAT? It is surgical complexity score. Okay. Surgical complexity score in the sense what all surgeries you need to give a proper cytoreduction. Okay. So what are the risks? See, some patients will have THBSO. Some will require the pelvic peritoneal stripping. Some will require lymphadenectomy. Okay. Some will require bowel resection, liver resection. So based on that, LAT scoring is given. Okay. So whenever it is 8 or more, it is high risk surgery. Okay. It's a high risk complex surgery. That is LAT scoring. What I'm asking is Eisenkopf score. Okay. For introp tumor assessment. Okay.
Repeat once, ma'am. Which is
for LAT?
No, this
Eisenkopf. Eisenkopf is for intraoperative tumor assessment. So now this is like nothing but little modification of whatever Fagotti has given. So what is the disease in upper quadrant? Okay, what is the disease in the pelvis? How much is the burden of the disease? So any small nodules are there, or less than 50% of the surface area, or more than 50% of surface area? Is it involving the omentum? What omentum it is involving? It is infracolic or total omentum. Okay. And in pelvis, if it is adnexal disease or any other metastatic deposits are there in pelvis. Okay. And is it stuck to bladder or rectum? Is there any disease in the retroperitoneum? Okay. If it is there, whether it is less than 1 centimeter or more than 1 centimeter. And apart from this, the central abdominal disease like serosal implants. Okay. All these things are considered to assess the tumor burden. Okay. Intraoperative. Eisenkopf scoring.
Ma'am, can you spell it, ma'am? We are not aware.
EISENKOP.
Okay.
Okay. Eisenkopf.
Excellent.
Yeah. So apart from this, so we discussed that Sudan criteria. No, Sudan criteria is something that will take general performance status and patient characteristics along with what is the burden of the disease to give a total risk score and how much chances are there that you will leave the disease behind. Okay, so that is Sudan criteria. Okay, so these are now you tell me. One of you tell me. What is peritoneal carcinomatosis index? What are the things you take in that? And what is the significance of it in the ovarian neoplasia?
Ma'am, we asked for peritoneal deposits. It has 13 regions. We have scoring from 0 to 3 based upon the size criteria, ma'am.
What is CC0, CC1, 2, 3?
No macroscopic deposit is CC0. Less than 5 mm is CC1. 5 to 5.
No, 2.5.
No.
2.5.
Don't get confused with the other one.
Yeah, that is PCI that you are taking 5 mm.
Less than 0.5 centimeter is 1.
For CCR,
no,
ma'am is asking. So CCR 0.
Size is score.
Are you asking CCR, ma'am? Okay.
Less than 2.5 to 2.5 centimeters, mm to centimeters, and more than 2.5 centimeters.
Okay.
Yeah. What are the quadrants and what are the regions?
0 is umbilical and momentum. Central quadrant and 1 is right
13
hypometrium.
quadrants and total 39 score.
Yeah. Right upper epigastrium, left upper
lumbar, left iliac,
pelvic, right?
Last four, it is in the bowel. Jejunum,
bowel is
Upper jejunum, lower jejunum,
upper iliac,
lower iliac.
Okay. And what is now somebody was telling? What is the lesion score? Lesion score is different from CC score. Okay, don't get confused.
Yes.
Lesion score is to calculate the PCI. Okay.
Yes.
After you do cytoreduction, what you calculate is CC score. Okay. So they both are different. Lesion score?
0, 0 to 5 mm and 5 mm to 5 centimeter.
More than 5.
0.5 centimeters, 0.5 to 5 and more than 5. Yeah. So what is the minimum PCI? What is the PCI cutoff? Anything in ovary?
39. Minimum is 0.
There is no cutoff as such for ovary.
Yeah, there is no cutoff for ovary. Okay.
But still
There is more of a prognostic.
Yeah. So what is the thing that says that the PCI of more than this in ovary, they don't do well much.
Yeah.
Or it is complex.
They sent for NACT, more than 20.
Yeah. So it is little controversial area, but in ovary there is no cutoff. That is the bottom line you should remember. Okay. So if there is anything more than 24, so the possibility of giving like CC0 is very less. So that is we have concluded. Okay. So now coming to yeah. So now we'll discuss about what is the what are indications for NACT. Anybody can tell staging in ovary?
1A, 1 ovary, 1B, both ovary. C is ascites. उसमें spillage, surgical spillage and
C1 is
C1, C2, C3 है ना?
C1, C2, C3.
Yeah. C1 is surgical, 2 is pre-op, and 3 is ascites.
Yeah. And next, 2?
2 involvement of uterine segment
adnexa.
Pelvic organs, pelvic peritoneum 2B.
2A, adnexal involvement or uterine extra. 2B is other pelvic organ involvement like bladder, bowel, bladder.
Yeah.
fallopian tube and uterus is 2A और उसके अलावा कुछ भी pelvic तो 2B ना?
2B.
Yeah. What about 3?
C 3 we already said na ma'am that 3A 3A1 A2 and retroperitoneal lymph nodes is 3A1 and extra pelvic peritoneal mets is 3A2.
Microscopic or small.
So again that classified, no? A1, A2 is
less than
A1 is
10
how much?
mm and more than 10 mm in diameter is A1 1 and 3A1 2.
A1 2. Yeah. Then B is
3A2 is microscopic extrapelvic disease. 3B that is up to 2 centimeter any peritoneal mets and more than 2 centimeter macroscope mets in the pelvis is 3C. Or spleen ka capsule and liver ka capsule is also come in this. But if parenchyma involvement is there, then it is coming in 4.
so now yeah. So
And
what is
pleural
the
effusion with positive cytology is 4A. If pleural effusion is there and cytology is not there, then we won't be saying it's 4A.
okay? So just 1-2 points I forgot. Just what is the indication for upper GI endoscopy in ovarian neoplasms?
That
bilateral ovarian tumor.
CA 125
CA 125 score is more than 25.
Ratio less than 25.
Less than 25 and GI symptoms. In that case, we have to do upper GI scopy as well as colonoscopy. or if there is Krukenberg tumors.
Bilateral.
Yeah. Then what else? What one more thing? Yeah.
One thing. Syndrome.
So Krukenberg, since you alluded to, what are the CAs which present with Krukenberg metastasis?
Stomach, breast, colon.
Gallbladder also.
Stomach, colorectal, and breast, most common. Okay. Yeah. So what about yeah? What is if a patient presents with any serosanguinous watery discharge PD, which is otherwise called hydrops tubae effluence, what is your take on it?
Fallopian tube malignancy.
Fallopian tube malignancy.
Generally, there is fallopian tube. Okay, fine. So, yeah, coming back to our discussion. So, what is the treatment of choice in ovarian neoplasms?
Surgery.
Surgery.
Yeah. Mainly it is surgery. So, when do you consider for NSCT? What are the indications for NSCT?
When the performance score is not good, patient needs to be optimized based on the nutrition, or the tumor burden is so large that the possibility of getting a CC0 is difficult, or if there is a to down stage. In those cases, NACT is clear-cut in.
Fagotti et al. Has given one criteria to define when to give patient for a new adjuvant. That is peritoneal implant more than 2 cm, bowel mesentery involvement, omental extension to spleen, stomach or lesser sac, or pelvic side wall involvement or hydroureter, suprarenal para-aortic nodes more than 2 cm, infrarenal para-aortic more than 2 cm, suprarenal para-aortic involvement more than 1 cm, ascites more than 500 ml, diaphragmatic disease, and superficial liver mets but of size more than 2 cm.
So, easy way to remember is most of this are extension of Fagotti. So, if you remember that criteria, in addition to that, ascites will come. One more thing what you forgot is extra abdominal disease. Okay. In that case, their preference for NACT. So, can you tell me 3 studies which have told, NACT is superior or is it non-inferior? What is your
non-inferior?
Non-inferior.
Yeah, quote me 3 studies which have told giving NACT in
MRC, Chorus, Scorpion trial, and URTC.
Yeah. So they were non-inferior studies, right? So
they said if we are doing and giving NACT to these patients, overall survival there is no difference, but post-op morbidity is less.
So what was the problem with Scorpion criteria?
They had included stage 4 patients as well, and bevacizumab was also used in these patients.
4 points are there. And bevacizumab used, stage 4.
And mortality rate was 8%.
And ascites.
Yeah. Sorry? Mortality rate was high, correct?
8%.
Fourth क्या है मैम?
And I think का कुछ follow up का था या no? I think I also forgot. I'll tell you. Okay, just give me some time. Then yeah. So NACT ka we'll discuss. What about surgery for epithelial ovarian cancers? What is importance of surgery? We have discussed the surgical is the main modality of treatment. So, what was the importance of surgery? Is there any study that says
Achieving complete cytoreduction is the most important criteria in surgical management of ovary.
Yeah. What was
उसमें
that
मैम
study
ऐसा
which
कुछ
told
बोला
about?
है ना कि परसेंटेज ऑफ कितना ज़्यादा रिड्यूस करता है उतना ओवरऑल सर्वाइवल इम्प्रूव करता है.
Yeah. That's what is the study I'm asking?
Bristow et al. With every 10% increase in amount of cytoreduction, there is 5.5% increase in median survival.
Yeah. So, yeah, Bristow et al. Then next, what is the types of surgery in ovary?
Primary debulking surgery, interval cytoreduction surgery, secondary cytoreduction surgery, and has a palliative surgery.
So, what is primary cytoreduction?
Primary cytoreduction is upfront when we do it is primary cytoreduction. Interval is after 3 to 4 cycles of chemotherapy. We reassess and then do the
मैम वो
cytoreduction.
जीओजी क्राइटेरिया वाला मेंशन करना है कि नहीं कि पहले लेस देन 1 सेंटीमीटर को ऑप्टिमल साइटोरिडक्शन बोल देते, बट अब
No,
बोलते हैं
nothing, no gross visible disease. Now it is no gross visible disease.
ओके.
Yeah, tell me. So, staging laparotomy.
Staging
Primary
laparotomy, primary cytoreduction, interval cytoreduction, secondary cytoreduction when it is done for recurrence, and palliative when it is done for symptomatic relief.
Yeah, what is second look surgery? Second look laparotomy.
That is only done on trial basis after completing of chemotherapy to just for assessment.
Yes. Okay. So, what is palliative cytoreduction?
When the patient has obstruction, or if there is to just relieve the symptoms when we do, that is palliative.
What is secondary cytoreduction?
For recurrence, when we do, when the patient has already received a primary treatment previously, either a surgical and chemotherapy, now has a recurrent disease, if the patient falls into the desktop criteria, then we do secondary cytoreduction.
Yeah. So, interval is after chemotherapy.
After 3 to 4 cycles.
Okay. So, what do you do in cytoreduction?
First, we need to assess the disease, extent of the disease that is present. If there is any abdomen, mesenteric disease.
हेलो हेलो आवाज आ रहा है?
यस मैम आ रहा है.
मुझे किसी का नहीं आ रहा.
मेरा आया मतलब अभी.
अदिशिता का नहीं आ रहा है. हेलो.
I was taking a call, I think.
अच्छा.
Yes.
Hello. Rationale behind this spread in ovary?
The peritoneal current. So, the basically in ovarian cancer, it's a surface release of cancer cells happen which follow the route of the peritoneum. Usually they get deposited either in the diaphragm or the fixed areas like duodenum or cecum, or in the paracolic gutters and the pelvis.
So they are all because of peritoneal movements or respiratory or
gravity.
Gravity. Okay, peristaltic movements also. So they get deposited all over the abdomen. Okay. So So then, what are the prognostic factors which you say that these are favorable factors in ovary and these are not favorable?
Age of the patient, grade of the patient, grade of the disease, whether it's a low grade or a high grade, and achieving complete cytoreduction, whether the volume ascites is present or not, stroke stage, performance state of the patient.
So age of patient, okay, they're less than 50 years, they're favorable. Then stage and grade of the disease. Okay. Stage 1 and 2 and grade 1. Okay, these are favorable. Okay, performance status, good performance status. Then
disease volume is less.
Limited disease. Yeah, limited disease. And any diploid. Okay, so these are, yeah. So there should not be any ascites, there should not be any mutation. Okay. So, in this context, I'll ask. So, BRCA associated ovarian cancers do well or do bad?
Do well.
They do well, but they're not if BRCA1 mutations are there, then they're favorable factors. Okay. If they're not there, then they're unfavorable. Okay. So, why BRCA we discussed. Okay. Generally, they respond to platinum well. Okay. Anything other than like clear cell and all that pathology, they do bad. Okay. So, the pathology also matters. Yeah. So, as we discussed, Bristow et al. And all. So, what is the impact of cytoreduction on like how much implant you leave, how much survival will be decreased?
So, if the deposit left, if there is no deposit left behind, CC0, then the expected survival is almost 40 months. And if it is less than 0.5, then it is 30. If it is 0.5 to 1 centimeter, it is 20. And if it is more than 1 centimeter, it is 10 months.
0.5 to 1.5. More than 1.5 centimeters. Yeah. So, what was this study?
Griffiths et al.
Yeah. Griffiths et al. So, what about the incidence of nodes in ovary? Nodal burden in ovary.
In stage 1, it is 25%. Stage 2, it is 50%. Stage 3 and 4, it is 75% is the risk of lymph node mets.
Okay. More or less correct. Yeah. So, what is the incidence of para-aortic nodes?
It's almost 25 to 30%.
It's around 40%, if I remember. Okay. Some 35 to 40%.
40%. Yes.
And what about omentum?
25%.
Omental deposit.
25%.
Yeah. So, and peritoneum also is same, no? Like yes. Omentum only, I think. Yeah. And what about diaphragm?
30.
Yeah.
30%.
You just remember in that order only, like omentum, peritoneum, and diaphragm, then comes para-aortic nodes. Okay, this is all in early stage. Okay, whatever we are discussing. What is the study?
Young et al.
Yeah.
Which is study?
Young et al. Okay. So now coming to chemotherapy. Okay. What chemotherapy you use for ovary? What is the dose?
Paclitaxel carboplatin.
What is paclitaxel carboplatin dose?
AUC 4 to 5 is for carboplatin and paclitaxel 175 mg per meter square.
So, is there any difference between giving 3 versus 6 in adjuvant therapy?
There was a study, GOG study and Action and Icon 1 trial where they've said that 6 is better than 4.
This is for only stage 1.
Stage 1.
Yeah, stage 1, 2 disease. Grade 1, 2 and stage 1 disease. Okay. And yeah, so what are the studies? What is radical oophorectomy? What is the types of radical oophorectomy? What was that study?
Esenkop et al. Had a classification.
What was it?
For radical oophorectomy, basically it is approached from the only hysterectomy with this thing is type 1. When we do sigmoid colectomy or rectosigmoidocolectomy also it is 2. 3 is when bladder and ureter is also.
Yeah. So, and what is the types of para-aortic lymph node dissection?
There is A, B and C. A is when we do a proper systematic para-aortic lymph node dissection. A1 is up to the above the suprarenal as well, up to the celiac. A2 is infrarenal. A3 is below the IMA.
Okay. B1, B2?
B1, B2 is when we just do the sampling. It is B1 and B2, and C is based on just palpation or.
B1 is what? B2 is what?
B1 is extensive para-aortic nodal sampling. B2 is minimal para-aortic nodal sampling.
Okay. C1?
C1 is just when we palpate after exposure.
One is direct palpation.
Indirect is C2, and C3 is on radiological when we assess.
Okay. What is this classification? Name? Formal et al. Okay. So, what is the incidence of lymph nodes in stage 1, 2, 3, 4?
1 is 25%, 2 is 50, 3 and 4 is 75.
Yeah. So, they differ with the type of tumors also. Okay. And can you tell me something with cytoreductive surgery and survival, like with in relation to stage and grade?
Cytoreduction surgery, survival.
What is the most common stage of presentation of CA ovary?
3C.
Yeah, 3C. So what is the survival in that?
Around 10%, 10 to 30%.
10%. Okay. So yeah, 10 to 30% is in stage 3 as such. What is in stage 1?
Stage 1 is around, depending upon the grade. If it is grade 1A, 1B, then it is almost 90 to 98%. If it is grade 3 or poor, then it is around 60 to 80%.
Okay. So median overall survival is how much in ovary?
Median OS is 30 to 40 months.
Yeah. Then what about suppose what is the trial which told about advanced stage treatment with chemotherapy? So how much survival was there in serous versus mucinous? Serous do well or mucinous do well?
Serous do well than mucinous.
Yes.
So should we tell it in NACT? That statement is there now for McKenzie, that meta-analysis. If stage 3C with implants more than 4.5 centimeter, NACT has less morbidity after cytoreduction. So we should send
after NACT, cytoreduction has less morbidity.
Yeah. So we should tell it as an indication for NACT.
As of now, NACT is non-inferior. That's it. Okay. And the 3 studies that you should quote is what we have discussed: Scorpion, MRC Chorus,